Okay.
You can start.
I'll wash my hand and introduce myself. This is Dr. Muzna. I will tell cute little Kamal, is it fine? Can I examine you?
Yes, but you
I
will
will
talk
expose.
to the examiner, right?
Yeah. Yes. So I will then take. I will tell him to expose himself.
Yes,
Comfortable.
he is exposed already.
As per
Please
the,
open your mic. Okay.
he's adequately exposed. I will see whether he is well or he's in distress. I will
Not in
see.
distress. I will give
Oh,
you the finding. Not in distress.
okay. I will then try to see his growth. How is his height, weight, and head circumference?
Height, weight,
And
and average build.
okay, then I will see in the surrounding for any supporting aid, any medication, anything that can give me a diagnostic clue. I will.
No, nothing in the surrounding.
I will just see his face whether that looks syndromic or no.
No, not
I,
syndromic.
I will tell him to smile to see any deviation of the angle of the mouth.
No deviation.
Then I will do the upper limb. I'll see, just inspect the upper limb to see for any scars, any wasting, any involuntary movements, any fasciculations, any tremors.
Uh, no involuntary movements, no fasciculations, no tremors.
Any deformity that the child has.
You can see the deformity.
As per the universal cue, I can see that the left elbow is kept in a flexed position and the wrist is in pronated position. And
Yeah.
it's the shoulder is adducted. So I will now check I will ask him whether he has any pain anywhere, and if
He has no pain.
okay, and if at all, I'll do some maneuvers on him. If he has any pain, let me see. As per the universal cue, I can even see that the child has low set ears and webbing of the neck, mild webbing of the neck that is present. I will.
He's not syndromic. He's not
Okay.
syndromic. I told you before.
Okay. So I will see check the tone of the child by telling him to move his arms like a chicken wing. If he can do that, putting it up, out, and in.
Yeah, his
That's a, sorry, that's the.
tone is
I will check.
his tone is reduced on right side, on right shoulders.
Okay, right shoulder. I will. Okay, I will then check for the tone passively in the elbow joint by doing flexion and extension.
Yes, there is hypotonia.
Hypertonia, increased tone on the
hypo.
hypotonia on the right side.
Yes.
Okay, then I will even check the tone on the wrist joint by doing rotatory movement and compare on both the sides.
Tone is fine. This joint tone is fine.
So only the shoulder and elbow.
Yeah.
Okay, fine. Then I will check the power by telling the child to take his arm inwards. First, I'll do this with resistance and then without resistance and then with resistance, whether he can do this adduction.
In the his hand is already adducted. On the left side he is doing normally, but on the right side he is already adducted, and it is power is grade 4, I can say.
Okay, then I will tell him to take his arm outwards and whether he can do the abduction with resistance and without resistance.
Left side he can do, right side he can't do.
Right side he cannot abduct. Okay. Okay, then I will tell him to do to bend his elbows, and this with resistance and without resistance on both sides, whether he can do it.
No, he is not able to bend his elbow. In the same position he will keep, but the left side he can do.
Okay, right side he cannot bend the elbow. Okay, then I will see whether he can open up his elbows. The right is already open and it is adducted and it is in the pronated position. So I will ask whether the left he can do with resistance and without resistance.
Left he can do.
Okay, fine. Then the wrist, I will tell him to take the wrist inwards with resistance and without resistance on both sides.
Yeah. Left side he can do. Right side he is holding in the same position. He cannot supinate it for you.
Okay, and whether he can take it outwards away from his body, the wrist, in an extension.
He can do. He can do it, but he cannot.
On the right side also.
Right side he can do that, but he cannot supinate. Okay.
Okay, fine. Then I will give him my fingers in both the uh, uh, hands and tell him to pull it to see the grip.
Yeah, he
How is the
can
power
do it. He can do it.
on both the sides?
Yes.
Okay. Then I will check for the reflexes of check his reflexes by flexing his bicep elbow and hitting with a tender hammer on the biceps tendon on both the sides and seeing for the flexion of the elbow.
There is a hyporeflexia here in the, which one you want to check? Biceps?
Right side and
Hyporeflexia.
left side both I will check.
Yeah, left side is normal, in the right side.
Okay, fine. And then I will check for the triceps reflex also by hitting on the triceps tendon backwards and seeing for the extension of the elbow.
Already the elbow is extended. It will be hyporeflexia on the right side, but on the left
Okay.
side it is normal.
Okay, then I will hit on the supinator tendon and see for the flexion on the right side and the left side.
Left side he can do normally. Right side he keeps the hand in the same posture.
Okay, then I'll take a cotton wool and tell Kamal, see, this is the way you're going to feel it. I'll show him the feeling on the chest and then tell
Examiner
him to
says
close.
no need to do sensation. Okay.
Coordination, I would like to check.
Yes, in the left hand he is doing normally. In the right hand he cannot do because of his problem.
Oh, okay,
Because
then
of
I would,
okay.
yeah, my
So
6 minutes
what
are
you
not
want
over.
to do?
Okay, then I will check for the clavicle. Is there any fracture, any
The
scar?
clavicle is there here. Clear it is. No fractures. Okay.
No
Next.
fractures, that is.
Okay.
And I would like to check for the then I would like to check for the face. I will see for the eyes for any hearing aid, vision aid, hearing aid, any meiosis that the child has, or
No. Nothing.
any exophthalmos that the child has
Time
in the
is
eyes.
okay.
Time up.
Just few seconds. Okay. 13 seconds left.
Okay. Okay.
Anything
Then in the
else you want to
then I would like to this is done. I would yeah.
do?
That's
Can you finish? Tell your in
I
order to
would like
my examination.
in order to complete my examination, I would like to do the complete neurological examination, especially the lower limb, the cranial nerves, the cerebellar system for this child. Uh, yeah, and I have checked for the fracture. So this basically, I would like to do the entire neurological examination, plot the child on the centile chart, and measure his vitals for this child.
Okay. Vitals, plot the site and central chart, cranial nerves,
An
lower limb
ophthalmological
examination.
examination also. An ophthalmological exam.
Okay. So tell me your differential diagnosis for this case.
I'll present my case. I've seen a
Yeah, present. Yeah,
5-year-old
sorry, present.
5-year-old Kamal who seems to be well and well grown for his age, which is no syndromic features, with uh, with tone which is reduced on the right side, with reduced power at the shoulder and the elbow joint that is there, and with no reflex, with hyporeflexia of the biceps as well as the triceps tendon, and mostly having a lesion at the C5 and the C6 level, which is probably a lower motor neuron lesion, due to which this and has a upper limb, right upper limb being in a position of adduction, extension, adduction at the shoulder joint, extension or at the elbow joint, and pronation at the wrist joint. So mostly this is a lower motor neuron lesion, which is at the C5 or C6 level. So this, because of the age of the child, this is mimicking like an Erb's palsy. But because of the age of the child, I will be thinking of some spinal lesions like syringomyelia or spinal trauma that is at this level.
Okay. So this is Erb's palsy, but you are giving other differentials.
Because the child is
Uh,
too, the child is too big for this. But if, of course, if yeah,
So what
Erb's
your
palsy.
so how do you want to treat this child, manage this child?
Yes. To manage this child, I'll take a focused history, plot the child on the centiles, uh, measure the vitals of this child, do the physical examination, as I said, investigate this child in order to confirm my diagnosis, although not required, and a new nerve conduction study can be done to prove. A scanning can be done for the brain and the spine to see for any lesions which can cause this. The X-ray of the clavicle to see for any clavicular fracture, as well as the humerus to see for any humeral fracture which can cause this kind of trauma to the
Okay,
C5,
what
C6 or a brachial
multidisciplinary
plexus.
team you will involve?
The multidisciplinary team will consist of the pediatrician, of the neurologist especially, then the orthopedic surgeon if required, then physiotherapist, occupational therapist for this child, and uh, social worker that will be there. And the family should be involved, should be educated about this disease, where the physiotherapy will be required, and recovery, how the recovery is going to be, how the physiotherapy needs to be done, and treating the underlying cause will be important.
Okay, time finish. So you don't think that this can be due to birth trauma?
This can be due to birth trauma, which has left a residual. Very rare. The chances are that it's a few of them can have residual Erb's palsy, but that's why I said Erb's palsy. It looks like an Erb's palsy. It can be, but however, if it is acquired as per the history, I will come to know whether it is from birth, or if it is acquired, then I'll be thinking of spinal causes, or nerve
Spinal causes,
injuries
what
to
you
the
said,
C5.
syringomyelia.
I said
What you said?
syringomyelia, and I said spine trauma to the umbilical plexus, that C5, C6 level. So very rare.
Okay.
Hello. Hello.
Yeah.
Yeah, you told about Dave's palsy that is involving C5 and C6. What is the movement of the hands, right hand? So I think it is also there is clunkies. That is C5, C6, CA7 and
Had
8.
clumky has been there. She gave me a very good grip when I was holding. She gave me a very good
That
grip,
is why I
and
gave you the good grip.
that is why
And I
she gave me a
also
good
told
grip.
you when you are in your presentation also, I had told that the tone is reduced only in the shoulder and the elbow. For the wrist, I had
Yeah,
told it there was good
yeah.
tone.
And
But
even
you
wrist
cannot
extension
present
and
this.
flexion were done very nicely. That's why I was very sure that C7 and C8, T1 is everything is intact. But then, Dr. Noor, why have you marked the left elbow for me?
I don't know. It's in the
I
picture.
thought it's GI or something of the left. I'm thinking of that.
I don't know. It's the picture only. I don't know. But here it is clear, you know.
Yeah, but your findings were quite very obvious. That's why then I had to just track on the proper.
No, sometimes what happens, okay, I had to ask the questions, but you know, I want to tell you, there will be only 3 minutes discussion and examiner will not like repetition. Like you told vitals in order to complete, then again you told in management vitals. This will
Yeah.
waste the time and they will get irritated. I keep in one place, either in order to complete or in your management. In
Okay.
one place. Don't tell in two
Okay.
places. It will waste your time. You told vitals,
Oh,
complete examination again in the management. No, when you told in order to complete my examination, I will do other like lower limb examination, CNS examination, vision examination, whatever you tell, all after you telling. If you tell vitals here, don't tell vitals there. Okay.
okay, fine.
Don't
Yeah.
repeat it.
I agree, because 3 minutes is a very small time. Repetition is very big.
And for the management, you said nerve conduction study. Okay, let's go through what we do in Bell's palsy. This was actually a residual remaining, means, okay, let me ask some questions on Erb's palsy. So when do you, like, after birth, what are the common causes of Erb's palsy?
But Erb's palsy can be because of the high macrosomia. The child is very big, or difficult delivery that has been there, a shoulder dystocia that has occurred, and or a humeral fracture or a clavicular fracture, or yeah.
Okay, so how do you treat it during the birth? If this has happened due to
So
macrosomia,
basically, if it has birth, it's there.
what
Then
do you do?
5 days. 5 days you need to give rest to the child. You cannot do any active movements for 5 days at least. You have to give rest for that child. And after 5 days, we need to start with the physiotherapy for this child that is there. And the hand movements, the good prognostic factor is the hand movement. So see whether if there are active hand movements in the child's this coming back is very good. At the same time, I need to even check there is associated clavicular or humeral fracture that is present, or any associated signs of Horner syndrome that is present. Then after the physiotherapy, I should even teach the mother how to swaddle the child, not to keep the arm unprotected. I should teach the mother how to dress and undress the child. While dressing, I should first, the mother should dress from the affected arm and then the unaffected. And while undressing, the unaffected arm should be removed first and then the affected arm. So teaching the mother for dressing, undressing is important. And after that, every time we need to just follow up to see how the things are improving. Most of them
How
generally 80
often
to
you
80.
follow up? How often you follow up?
Uh, I know that I'm not sure. I'm not sure about that. How often? I think 6 weeks, but I'm not sure.
Anyone can tell how often is followed? Okay, then next I wanted to ask one question. So when do you refer to orthopedic surgeon this patient?
There is absolutely no improvement in 4 weeks. Means there is no improvement that has been seen.
Or 3 months?
And for, please pardon.
3 months or 4 weeks?
Okay, 3 months.
Normally it will improve in 3 weeks. Normally the baby will improve in 3 weeks, but after 3 months, still if you see the symptoms, they will be referred.
Okay, it's the same, it's static and absolutely no improvement, then we will.
Yeah, and also sometimes what happens, like these cases which did not improve in 3 months, they will do some corrections. Okay. And if the corrections are failed, I mean, now you don't see a typical waiter tips hand in this child. Some movement is there, means little is keeping it, right? It's not like typical waiter tip hand. That means it's partially corrected. So it needs full correction. You can give
nerve graft
and shoulder dystocia as the diagnosis. You can tell that it's not corrected. Still there is it is either partially corrected and still needs treatment like this. Okay, I will share some things to know about it. Just 1 minute.
चले जाएंगे.
So Ehr's palsy is caused by damage to brachial plexus during delivery of the neonate. This is mostly for the 5th and 6th cervical nerves, that is C5 and C6. And upper plexus palsies are more common than the lower plexus palsies. And 50% of the cases are associated with shoulder dystocia. So what is the common cause for shoulder dystocia? Macrosomia, right? Hello?
Yes.
Yeah. So macrosomia, and he in maternal factors, he has written maternal propulsive forces. Two things: fetal factors, macrosomia; maternal factors, maternal propulsive forces. Next is the And another one is the maternal raised BMI, means she's becoming increasing in her weight, and presence of gestational diabetes may also have been reported as the risk factors for this. Okay, at the again high birth weight, macrosomia, long second stage of labor. So in one point we can say tell here as the difficult labor also. Okay, for this long second stage of labor, we can tell difficult labor, macrosomia, and also there are maternal factors like gestational diabetes in the mother, increased BMI in her, and also the maternal propulsive forces. So in 50% of the cases, shoulder dystocia is the commonest cause. Okay, so how the arm will be, the infant is unable to abduct the arm from the shoulder, okay, and rotate the arm externally from the shoulder. He cannot do that. So there will be adduction and internal rotation, and he cannot supinate. So there will be pronation. So adduction, internal rotation at the shoulder, and supination of the, pronation of the forearm. Okay, so it is called as Vater's tip, which we all know. Next is the clinical signs. What you see, as I said, adduction, internal rotation, and pronation. So forearm extension is normal. Biceps reflex is absent. That's why when you asked, I told hyporeflexia because this is partially treated. It can be absent as well if it is typical Vater tip hand. Okay. In children, usually you will do this Morrow's reflex. If it is less than 6 months child, you will do the Morrow's reflex. So it will be absent on the side of lesion, on the affected side. So you will do it in infants, not in this patient, less than 6 months. So sensory impairment on the outer aspect of the arm. There can be sensory impairment, but I told no need because sometimes the time factor, they may say no need. Okay, in the outer aspect of the arm can be there, but here it's written unusual. So it can be there, not has to be there. Power of the forearm is normal. If impaired, it suggests injury to the lower part of the plexus. Okay, so mainly the affection is at the shoulder and also for the supination. Hand grasp is normal unless the lower part of the plexus is damaged. So this was the clue for her when she told that I will do the grasping of the hand to check the power. I told that it is good. Okay, but now I have a doubt. He's telling forearm. So, but since the child will have his hands in the pronated position, will he be able to flex the hand? No, right? So how you will test for the power of forearm is normal? Can someone comment on this?
Like, this is the power of the forearm. It means like he's able to flex. Yeah. It means biceps is intact, right? If you are checking the power of the forearm.
Extension will be there, means absolutely, even means if the extension is not there, then I think it's clump case, right? But
no, he has kept the hand in adduction and external.
I understand your question. How will you check
extended at the elbow and pronated? He cannot do the action of supination. Okay, so we have to check this. Okay, maybe supination is by C5 and C6. That's why.
Yeah, supination is C5, C6. But I'm wondering, how will we check the flexion? I'm wondering.
Yeah, we have to check this. Flexion is by the action of biceps. Actually, flexion is by the action of biceps. Okay, since he is telling the biceps reflex is absent, that means this action is also gone, the flexion at the forearm. So the good you have, the good will be in the hands, like wrist, the tone of the wrist, the hand grip, all these things will be good. From this you will rule out that there is no clump case involvement, mainly in the hand, not at the elbow. Okay, but we can.
They were speaking about the muscles of the forearm, right? I mean, can you just show it again, Dr. Noor? Power of the forearm is normal, right?
So the forearm muscles will connect to the.
Yeah, so if we check forearm muscles, basically we are checking wrist flexors and wrist extensors.
Yeah, you're right. That's why the elbow is affected here. Biceps is affected. Because
Yeah, so we, even if it isn't supination, we can do the flexion of the wrist and extension of the wrist. So that is okay.
yeah, I got your point. So here the biceps is affected. That's why you cannot elicit the reflex at the biceps, and also the flexion you cannot do because the action of flexion is by the biceps. Okay.
Dr. Fatima, I have one query here. Power of the forearm, he's telling normal. When we are checking the power of the forearm, it is like flexion and extension, right? And for the flexion, C5, C6 will be affected. Or like for the biceps, it's
No,
C5,
he's
C6.
telling the forearm muscles will be, the action of the forearm muscles is on the wrist.
Yeah, but when we are checking, what he mentioned, power of the forearm. When we are checking the power of the forearm, it is like you are.
Yeah, let us understand. Let us see. Go back and see what all C5,
If
C6 is
if
innervated.
he
Will affect.
if he would have told like power of the forearm muscles, I would have understood. But if
Okay, no
he's
problem.
telling, yes.
We will make it as muscles because we know that the biceps is C5, C6 and it is affected.
Yes.
So he cannot flex. Okay. Here, so investigations, you can do the MRI, shows nerve root damage, and EMG and nerve root studies are not helpful in determining the extent of damage and severity. This is, however, been opposed. So are we doing routinely MRI? I don't think, right? More than 3 months, if it presents, then only we do. Can someone comment on this? Your differential diagnosis can be clump case paralysis, clavicular fracture, fractured humerus, and CP. This was told by Dr. Muzna. She told clavicular fracture, she told fractured humerus, but she did not say this because she was clear with the hand grip. Okay, and also you can put CP. These three can be put as your DDs. Then the management. For the management, you will put intermittent immobilization and positioning to prevent contractures. So if the child continuously keeps the hands like this, there will be contractures. So positioning has to be done. Okay. Intermittent immobilization and also positioning to prevent positioning. How you do positioning? In the opposite direction. Now there is adduction, you will do the abduction. There is internal rotation, you will do external rotation. And for pronation, you will do supination and extension at wrist with the palm turned towards the face. This will be taught by the, I think, the physiotherapist and the orthopedic surgeon. Okay, about the positioning. Dr. Muzna, this is what you are telling, that mother will be taught about this.
Yeah. The swaddling and positioning. Yeah, swaddling and positioning should be taught. This was what I was.
This is
But
what,
I did not say exactly the entire positioning. I did not tell. I just said.
it's
I
okay.
think
But we have to tell. If they ask, you will add, because in 3 minutes, what you will tell? If you will tell the positioning, and if he asks, you can describe the opposite of the lesion. You will do, like there is adduction, you will do abduction. There is internal rotation, you will do external rotation. There is pronation, so you'll do supination and extension at wrist with palm turned towards the face. This is the positioning if they ask you. And also there will be gentle massage, physiotherapy with active and passive movement exercises by the end of first week. That means, as you said, first 5 days you will not do anything. You will start after 5 days this treatment, active and passive movements. Okay. Electrical stimulation may prove to be beneficial. Okay, refer to neurosurgeon. This is what I was asking you. Refer to neurosurgeon if paralysis persists beyond 3 months or if there is proximal damage to the plexus. So what are the two indications to refer to neurosurgeon? Will be persistent palsy for more than 3 months, and also if there is more proximal damage to the plexus. Okay. Surgery can involve direct neuroraphy after neuroma resection neurolysis to remove any scar tissue, and nerve grafting with transplant to another nerve and nerve transfer to local functioning nerve. However, results are mixed, and pain along with functional disability and persists in significant numbers. This is what I'm telling. They may do some surgeries. I don't know, should we remember these names or not? After surgeries, there can be still functional disability and persistent of some signs. Okay. So they will refer to orthopedic or neurosurgeon, because here he is telling neurosurgeon.
I think it's neuro only, orthopedics. Only
Neurosurgeon.
one and one.
Neurosurgeon. Because I remember reading in the neonatal guidelines as orthopedic. Okay.
No, I think this neurosurgery.
No, no.
There also it was neurologist. I think.
Neurosurgery only.
Let me check. Just wait. Before that, I want to ask you about what does he mean by more proximal damage?
Above C5C6 maybe.
This is
Then it may be affecting the
C5C6 means
diaphragm or
not
something.
involving the diaphragm, right?
Yeah.
C4 and all.
C4
Yeah.
and all.
So when you see any
Yes.
respiratory symptoms, maybe along with
Yes,
this.
yes.
And so always remember this question will be asked. When do you refer to the neurosurgeon? If the paralysis persists beyond 3 months, this is very important. And you will, regarding the surgery, some surgeries will be done. You will just tell him, no need to remember all these things. No. Surgical involvement.
how frequently to follow up, Dr. Noor? That answer was?
I think it's there in neonatal guidelines. Just 1 minute.
Okay, wait.
I will share because there is some doubt for me also. Books. This can come as video station as well. Okay. I think video station is more common than the upper limb examination. You can see the screen or no?
No.
Wait. क्या कर रहे हैं इनसे? कौन सा ये है कि okay. See here, upper limb birth injuries including brachial plexus. Brachial plexus palsy may be congenital, occurring in utero, or acquired due to injury to brachial plexus nerves sustained due to stretching of the nerves during delivery. Okay, so it can also be congenital, he's telling, and acquired due to stretching of the nerves during delivery. Fractures to humerus and clavicle can also be the cause, and isolated radial nerve palsy of the newborn can also be seen. Okay. So assessment of all babies with reduced upper limb movement. Examine the arm and neck for swelling. So you will examine the arm and neck for swelling, bruising, tone, posture, degree of movement. Assess for breathing difficulties and Horner's syndrome. Document findings clearly. Explain to parents that recovery probable but may not be complete. This you have to explain them. Just if you get in a communication scenario also, tell that is probable but may not be complete. You are not sure at that moment. Okay. Inform consultant obstetrician and pediatrician. So if not in this case, if it was a small baby, you will tell even the obstetrician and pediatrician. Management. You will do X-ray humerus clavicle to exclude fracture. This was told by Dr. Muzna. If fracture of clavicle clearly seen, reassure parents and review at 3 weeks when movement should be returning. So you did X-ray, you saw fracture clavicle. What is the management? Just reassurance and review at 3 weeks. If fracture of humerus is clearly seen, offer strapping the arm to the chest for comfort. So strapping the arm to the chest, that means you will immobilize, and you will inform this Birmingham Children's Hospital orthopedic team to arrange follow-up. If uncertain, refer to children hand and upper limb service at BCH. Again, same. Classic waiter tip position. This is our thing now. Refer to children's hand and upper limb service at BCH as soon as possible. Initiate referral to local physiotherapist. Paralysis of the arm, which is completely resolved within a few days, does not need to be referred. But if there is any doubt, all babies will be seen in the regular 4 times weekly hand trauma clinic, so that specialist assessment can be made and parents can be given appropriate information. He is telling that if you have any doubt, they will be seen 4 times a week. I don't know, in the hand trauma clinic.
I think it's like the clinic must be 4 times a week. I don't think same baby will be seen 4 times a week.
That means weekly once it will be seen.
I'm not sure about that, but 4 times weekly clinic, I just understand that the hospital has 4 times a week this service available. I mean, for no baby, we do 4 times a week, right?
Yeah. All
But that
babies,
doesn't make sense.
all
Yeah.
babies will be seen in the regular 4 times weekly hand trauma clinic. So if the paralysis of the arm completely resolves within few days, no referral. If there is any doubt, you will refer to the hand trauma clinic, he is telling.
Yeah, Dr. No, the baby can go 4 times a week. We have a physiotherapy center like this for this. And 4 times, they do the passive exercise. They teach the mother about the exercise part. So yeah, baby can go because it is not a big deal. 4 times a week, a baby can come with mother and they will do some
And
exercise.
why they are mentioning particularly this hospital, Birmingham's Children's Hospital?
Because they have this center and this leaflet, I think in collaboration with the Birmingham Children's Hospital, they have, I think, a big center for this physiotherapy.
And you see here, he told for the humerus, you will refer to the orthopedic team. For the clavicle also. But for this, you will refer to the hand team, this one. Hand trauma clinic. And it is separate, he's telling hand and upper limb service. Hand and upper limb service. That means you can say this hand and upper limb service and neurosurgeon. If not improved in 3 months, you will do the neurosurgeon. So for follow-up, Dr. Muzna, tell this, if there is doubt, all babies will be seen regularly 4 times a week in hand trauma clinic. Whatever he has told, the same thing. Okay? You're hearing me, Dr. Muzna? Okay, that's it. 2 things we learned. One is the neurosurgeon and the
Yes, Dr. Noor, I'm hearing you. My phone is in my phone.
Okay, no problem. So 2 things, the referrals, remember, neurosurgeon, you will refer if more than 3 months the palsy persists. Usually it should improve within 3 weeks. Okay, if it persists, or you can also say few days, resolved few days, no need to refer. But if it persists beyond, you will be referring, if 3 months and more, you will be referring to neurosurgeon. But within few days, if it is not improved and you have a doubt, you will refer to hand trauma clinic. Okay, so this is hand and upper limb service. Okay, this is what was our case today. So any comments before we end the meeting? So here, just remember, within few days it has to improve. If not improved, first you will be referring them to hand trauma clinic 4 times weekly. But if this persists beyond 3 months, the neurosurgeon will be involved. And when you will do the MRI, it's not mentioned there in the patient info. Any other source you have? Maybe after 3 months only. I am not sure. If anyone has any other source, can tell me.
I guess a mark is written after 3 months, but let us check.
for MRI?
Yes, I think I read it in Mark, but let me check and I will send the group.
Okay, who is with me? Ilaf?
Yes.
Okay, just send in the group so that we'll all will be sure.
Okay.
Okay. I
After 3 months, you mean you will do MRI?
She is checking in
Okay.
for
Otherwise,
this-
only X-ray, right? This is the only investigation.
No, first what you will do when when you have any doubt for this upper limb injury after birth, you will do all these things, X-ray, humerus, clavicle, to rule out the injuries. Or if it is the classical waiter tip position, you will just wait so that it will resolve in few days. If it is not resolved and there is doubt, you will refer to this hand trauma clinic. And if it persists beyond 3 months, you will refer to neurosurgeon. But she's telling about the MRI. She will check in Mark. Dr. Mujna, do you remember where it is given that for the first 5 days, nothing will be done for the baby?
I read it from various sources. This neonatal guidelines has not given. It's given after a week you should start. And somewhere else also I read. I can't remember now.
Yes, physiotherapy should not be started in the initial
It should
period.
not be given. That it's definitely should not be given. I'll just see where I found this one. In my notes, it's there. Now I don't have my notes.
Even in the patient info, we read, right, that 1 week, I think it should be started at the end of the week.
Yes, at least 5 days, and better to be started after the first week.
Okay, physiotherapy with active and passive movement exercises.
Because the thing is, at that time there is active nerve inflammation, its swelling is there. So you can actually, you have to give time for the injury to heal. So that's the
By
reason.
the end of first week, okay?
Okay, Turner, I check in the Mark, not written. I think I confused it with something else.
Okay, no problem. Just tell. So for the investigations along with MRI, we will tell the nerve conduction studies.
They not written any investigation in Mark, but they said that over 90% of cases at birth will completely recover at the end of the first year. That's what is written in Mark. But we have to follow guidelines, I think, in the management.
Here for the management, he just wrote X-rays. He did not comment anywhere about the MRI. He just told you will refer to this hand and upper limb service. So better don't tell MRI. If it is persist, you will refer to the neurosurgeon after
neurosurgery.
Yeah.
Yes.
But beyond few days, if it is present beyond few days, initially you will refer to this hand and upper limb service. Okay.
Yes.
Okay. Done with Bell's. There is one thing I saw today, that all children with residual Erb's palsy, they are growing, and when they become big, they will do the operation. I will share, because Dr. Muzna thought because of this age, she will not put this birth trauma as the first. She can put it, okay? Because all these things, other things, syringomyelia, what you said, syringomyelia and spinal.
No, I think syringomyelia is very rare. I'm just reading.
Yeah,
I was just
keep it,
that only
it's a
spinal
normal-
trauma was fine. After I put spinal trauma. Trauma is still fine.
Put trauma
But,
as second, put birth trauma, and tell that maybe it's not, the baby did not improve after 3 months, and there maybe it's partially treated like this. Because this child, you don't see the typical features, right? He is keeping the hand little towards this side. So it's partially treated. He needs further treatment. So this will be your top of the diagnosis. The other you can put second as the trauma. The third you put your syringomyelia.
Okay.
Okay. So I think enough. We speak too much today. Inshallah, we will see next. Whenever is my meeting, I will announce in the group.
Dr. Noor, first you was reading from other website rather than neonatal guideline.
Patient
regarding
I read from patient.
Patient information. Okay.
Patient info, it's not much. It is just 1 page for this brachial plexus palsy. It's good. It's given nicely.
Thank you.